Okay, for this call, our ground rules are that we have 3 or more fire department EMRs or EMTs on the scene. Fire department has an incident commander, and the crew in the video is a paramedic transport ambulance crew with 1 paramedic and 1 EMT. We're in the system where there is a small hospital within 10 minutes of us called Mayberry General, and then the real deal trauma center is about 45 minutes away by ground. We work off standing protocol or protocols with standing orders, but we do have online available from the local hospital if we need it. Initial assessment of trauma patients is very similar to that of medical patients. We're looking at heart, lung, and brain, trying to establish the function of the neurological system, the function of the respiratory system, and the functioning of the cardiovascular system. A very rapid assessment. With airway and breathing, we're going to look, listen, and feel. Noisy airways are bad airways, and we want to be constantly vigilant of airways going downhill on us. Breathing assessment, again, is rate, effort, and depth. And then we may, in trauma patients, we're more likely to end up feeling for chest rise and respiratory depth than we would in maybe a medical patient. Radial pulses remain a key thing to grab right away. It's the best way to estimate a blood pressure, and in our really critically sick patients, we're not even going to measure a blood pressure. We just want to know if there's a radial there or not, and if it's strong or weak. If there is no radial, of course, we have to go check a carotid real fast, and we need to be cautious of checking radial pulses in extremities that have some injury that might be compromising a radial pulse. So it's not a bad idea to check radial pulse on both sides. We're looking for how fast or how slow that heart rate is. We're looking for skin condition, and we're going to try to control major bleeding. So again, the initial assessment's looking for hypoxia, hypoperfusion. We're looking for altered mental status, cool, pale, clammy skin, tachycardia, tachypnea, or the absence of radial pulse. If we find any problems with any of those, we're going to treat for shock, which is lay them flat, keep them warm, go fast, control external bleeding, and provide some high flow oxygen. Trauma patients get better at trauma centers. And so that is our main goal, is to get our patient off our scene and to a trauma center and safely and efficiently, and do as much as we can for them on the way, but absolutely manage their airway and breathing and maintain circulation to the best extent that we can. Secondary surveys on trauma patients, we may not even get to them on the most critical. But typically on critical trauma patients, we're going to do a rapid trauma exam, which will be a very rapid check looking for the rest of the possible immediate life threats that we've missed. Vitals will probably delay checking a blood pressure for real and getting the rest of our data until we get to the truck. The rapid trauma exam is a quick check of head, neck, chest, belly, pelvis, femurs. We're looking for big bleeds, big injuries. It's a very quick 30 to 45 second check. It doesn't particularly worry about arms and lower legs. We're looking for big immediate life threats, things that are bleeding internally or externally. We want to find all the bad things quick. We're going to get O2 on as soon as we can. We're going to constantly monitor and manage the airway in these less than alert patients and in our supine patients, even those that are alert. When they're supine and we have them immobilized or have spinal motion restriction in place, we've created a potential airway nightmare. So we need to be constantly on those, and constant reassessment is the key.
Okay, and what do you look like?
No, you don't notice anything abnormal whenever you come up here. I'm laying here supine on the ground.
Where are you hit?
I'm responsive to painful stimuli.
Yeah, see any big boo-boos?
No.
You got a radial?
I do. I have a rapid radial.
But you're not talking or nothing?
Correct.
Okay, and so what's your respiratory rate like?
Respiratory rate's about 30.
And is it deep or shallow?
Shallow.
All right, and so no radial?
No, you have a radial.
Yes, radial.
Yes, radial.
Less than conscious.
Yes.
Worried about airway. Okay. I need a driver and a trauma alert. I want to be in the bus in 2 minutes. I want to be rolling in 5. I need a backboard and a collar and the cart, please. So you've got airway this whole time. You've got airway. I'm giving a little O's. And then I need to do a quick exam here to see if there's potentially anything else, even though it doesn't sound like there is. And really, if you can hold that with your knees,
Yep.
so you can like use your hands and do some other stuff. Get some other stuff.
Actually put it on.
Yes. Yes. All right, so I have not been able to totally rule out anything on your head, right?
Correct.
So, I mean, under here, any mushy stuff?
No.
Anything on neck that looks obvious?
No.
I'm not gonna take the time to cut, but here, let's go. Go, go, go. Everybody moving all the time. I want off of this scene in 2 minutes. What, if I raise your shirt up, do I see anything?
You see some significant bruising on the left side.
Over here.
Correct.
And we're told baseball bat?
Correct.
And then what about belly?
Belly, nothing.
Is it rigid?
Nothing. No. Soft.
Soft?
Stable.
Stable?
Intact.
Stable?
Stable.
Stable? Don't care about that. All right, we ready? Okay. Call it, Nick. Go.
1, 2, 3.
All right, what's on your back, Chuck?
Nothing. Whenever you touch right about there, you feel a lot of crevice.
Right here?
Yeah, more in the rib area.
Gross. Does it look like it's a flail? You got your shirt all the way up.
It does.
It does look like a flail?
It does.
Holy crap. Okay, we gotta go. You guys strap, I'm getting the cart ready. All right, so he's got a flail. What should I do about flails, you guys?
Innovate.
All right, get those between his legs. All right, Nick, go set up the bus, please. In O2.
Inside bus.
Inside bus. Monitor set up. Spike me a line.
I got your back.
Get the airway stuff out, set it up, and make sure the suction works. Please. Go. 1, 2, 3. Up. Okay. You guys grab everything we left. Let's keep him warm. Okay, stay on his airway, talk to him. Actually, I will do that. You leave. I shouldn't jerk that off. Any difference?
No, nothing here.
Okay. Ready to hold still?
Yeah, you're losing the radio.
Losing the radio. Not good, I think that's all right.
Flail chest management. So definition, 2 or more adjacent ribs broken in 2 or more places. You have a chest wall segment between the breaks that doesn't move along with the rest of the chest. The underlying lung is also very likely to not be functioning very well. These are very difficult to stabilize with your hands or bulky objects. Positive pressure ventilation after tracheal intubation may be all that works. Keep in mind that the broken ribs are going to poke holes in lungs and livers and everything else, particularly poke holes in lungs. So flails can lead to tensions, can lead to pneumos and tension pneumos very easily. Speaking of pneumothorax, a simple pneumo can easily become a tension over time. And if you're having to use positive pressure ventilation, whether to ventilate your patient or in an attempt to stabilize your flail, you may speed that process up. Tension pneumos kill. Needle decompression is the key skill for us to perform. We're going to needle decompress, dart the chest when we have hypotension, measured by loss of a radial pulse, or blood pressures if you're that far into the call where it's appropriate to be doing actual blood pressures. So hypotension and decreased or absent lung sounds. Tracheal deviation is a very late sign, and JVD, although it may be present with tension pneumos, that depends on having sufficient blood volume to even distend those jugular veins.
Didn't hook, but you're all right. Nick, I want the bench seat. You got the airway.
Okay.
We're losing a radial.
Gotcha. You gotta line up.
Who's my driver?
Look at my little dog.
Yeah.
What are you guys?
Put that in the side. I need a real blood pressure. And then I need a machine on. So you're all about the machine. Get this over on the action area over there. Give me a real I'll get the real pressure.
Okay.
Go ahead and put the machine on that side.
Machine cuff.
Machine cuff on that side, then monitor second. And then capnography third. And then you can use that side. Capnography third, and then pulse ox last. Okay.
You do about 80 over 50.
Okay. Lung sounds?
Which side?
Huh?
What are you listening? Oh, you're listening to absent?
Lung sounds right here.
Absent. Absent.
Really?
Clear. Clear is shallow on the right side.
Shallow on the right side, back
Absent.
over here, nothing at all.
Absent on the left.
Okay. Yeah, we're going to have to start ventilation. Need a fire guy in the back. I need to go now.
You're in the front or back here?
I need you right up here. All right, you are mask seal, man.
Okay.
You are mask seal, and let's try a nasal. Chuck, will you take a nasal?
Yeah.
Okay.
Do we actually put stickers on them?
Just get it done quick and get freed up so you can help me with airway.
Okay.
All right, so I'm gonna lube a nasal and slide. All right, we're rolling, right?
Mm-hmm.
Okay. So we got 10 minutes. So you're Mr. This. I'm this. They don't really do it because it's really uncomfortable for them, okay? Okay, but your hands are tied up. Okay, and I'm doing this. Can I get air in, Chuck?
Yeah. You get
All
her.
right, you need to take this because I got to set up for a tube, okay? You good?
Yeah.
Get yourself stable, don't back into this and get hurt. All right, I don't see my video shit. Is there video? Video's in the top. Okay, so we're going to video first pass on this guy. Oh, so know where your stuff is, Wes. Thanks. Where is it? Down in there? Okay, so we're going to do this. I'm going to figure he gets a 7 tube. Keep my style out ready. Double check. Nick, is it okay to bag or are you having trouble?
Just having a little, it's getting tougher to bag.
Is he? Are you fighting him? Is the patient fighting?
No, it's just difficult to bag. Pressure.
All right, we need a dart.
I was gonna say, you want me to check one sounds?
Yeah. Well, he's down and we need a dart.
Okay.
So let's do that before I get too much further with this. And here's my dart. Holy crap, right here in front of me. All right, so we're going this side. I'm gonna find your spot here. You got your shirt off by now. Let's keep him covered as much as we can, but I need to be able to see from nipples down here. Okay. And I'm gonna go like right here on the patch. Hit the rib, bounce up and over, bury it, pull the needle out immediately, toss the needle in there. And if this strap is in my way, I'm gonna move it. Okay, so we got a dart in there.
Okay.
And we're gonna hope things get better, but you still need a tube anyway. Okay, so Anthony, you're watching that, because I gotta watch something else. What's your real heart rate, Chuck?
120s, 130s.
Okay, and what's your capnography waveform look like?
Capnography's good.
Okay, and you're doing capnography through a cannula in his nose for now, and then you've got that ready for me to use for this. Waveform's good, and what's your number?
Number is 35.
35, so you're ventilating surprisingly well for a guy with a flail who just had a pneumo. That's pretty cool. And okay, real pressure was what? Your
It was
80 over 50.
80 over 50.
Okay, and the machine's reading something similar to that?
Yeah.
And you cycled it again?
Similar enough. Sure.
Yeah, I mean, you're going to keep cycling it. All right, so I'm looking. Can I see? Are you fighting me?
Nope, not fighting.
Okay. Okay. I'm in. Okay, good. I'm holding this, and I need a scope in my ears. I need that scope in my ears. All right, Nick, work on, give that to me, and work on something to secure this with. Okay. Anthony, when I say so, bag. Okay, bag.
Clear.
Okay. Bag.
Clear.
Bag.
Getting lung sounds now. They're still diminished, but you're getting lung sounds.
Okay. Bag.
Clear.
Bag.
They're getting diminished, but there are lung sounds present.
Huh?
There are lung sounds present. They're diminished, but they are present.
All right, nice. All right, I got this. So I need to see how hard it is to bag. And then I'm going to turf this off to somebody, but I want to make sure I've, had a chance. We're probably pretty close. I'm sorry, I've been pushing really hard on the cheek. I just realized I've been really pushing hard. Because I'm holding this tube for real, man. Well, it's a habit. I'm not letting it up. All right, take the bag. I'll get that. All right. Okay. And then, okay, good. All right. Now give that to Anthony and give me a line set up. Well, we do have a line set up.
Yeah.
Very cool. All right.
Gravity bags over there behind Anthony.
Okay. So again, we're going to switch again. You take this. Anthony and I are going to switch places. You're secured now, right?
Yeah.
Okay. All right. How big a line will you take, Chuck?
I'll take it. For real or for nothing?
For the scenario, will you accept a 14 in the AC?
No, you can get a 16 in there.
Okay. All right.
I don't have that good of a.
No, I don't know. All right. In. Ow!
Oh.
Did you respond to that at all?
No.
No?
With withdrawal to the pain a little bit, but that was it.
Withdrawal all over?
No, in that arm.
So, okay. So Glasgow-wise, you're localizing, you're unresponsive. So there's a 1, and localizing is better than posturing. So that's like a 4 or a 5. And then what are you grunting and groaning probably?
That was a tube on my mouth.
Yeah, but before that.
Yeah, yeah.
So 1, 2, 3 total, and then probably a 4. So you're at the 7 or 8 mark. Okay, we're going to run this. Do you have a radio yet?
No.
And okay, we're going to run this wide open until we get a radio. We're going to check another pressure. What's the machine reading?
It's coming with 90 over 50.
Okay, so we're going to be kind of cool with that. We're going to think that most of what happened was the big air bubble, and it's blunt, and so there's not a tremendous amount of volume loss. So we're going to back that off to like a drop a second, or 100 an hour kind of thing. What about pulse ox? We've been able to get a pulse ox on that finger.
Yeah, the pulse ox was on here. It's reading in the low 90s.
Okay, so we're remarkably better than we were. And
Clear.
is there a chance you can make that stop?
I was trying. I thought
Whatever you did, do it again. Okay.
Yeah.
All right, and then how close are we? Close enough to give a patient report, probably?
I've been watching the time.
I don't know. Anybody been watching the transport time?
You've been on the monitor for 9 minutes.
Okay, so we're pretty much there. So my patient report, if I have time, is 20-something-year-old male assaulted with a baseball bat, unstable chest wall segment, had attention pneumo. We darted that. We now have lung sounds on both sides. Did not have a radial pulse. Does now. We got a line. We have a tube. Be there in 30 seconds. Okay. All right. Beep, 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 beep.
So, quick summary. Obviously, our patient was sick, decreased level of consciousness, so we made him a trauma alert. We got some help. We assigned people, and we moved off the scene really quick. We assigned somebody to take care of airway and C-spine while I finished the assessment, and then took that back over and sent the partner in to set up the bus, which would include setting up suction, O2, to monitor all the airway stuff, and then the IV is the last priority. And then made sure that we tried to assign people and helpers and make sure everybody knew what they were supposed to be doing, and we got moving because trauma patients get better when they get to trauma center.